little section here. Brain, pons, ella, circle cord, brain, anterior, middle, posterior, C1, 2, 3, and so on. We make a horizontal section through the brain stem at this segmental level, and we'll find, looks much like the previous one, midline, fourth ventricle, basilar groove, middle peduncle, and a fine separated basis from tegmentum of the pons. Looks almost exactly like the middle hindbrain segment, primarily because of the large bulbous pons in front, and it's only the tegmentum behind that's really drastically changing. In this segment, the motor plate is rather reduced. We do not have any medial group. We don't have any dorsolateral group. All we have is a lateral nucleus. Large motor neurons. Fibers come out. Through the middle of the pons laterally. And go out with the third division of the trigeminal, jaw muscles. And these are temporalis, and this gives it part of the topographical nomenclature that Houseman used for the biting segment. The sensory plate has its full complement of three kinds of cells in a ganglion that is semilunar shaped with small cells and fibers that go out through the third and then branch rostrocaudally, similarly with the second division. And with the first division, which way was first here, second, third. These small fibers serving pain and temperature out in the periphery for the face, which adds on to Houseman's biting segment, the face sensory component. Branch rostrocaudally, coming in, branching at right angles to the board in this diagram. And the ophthalmic first division coming in ventrally and descending down into about C2, structure C1 and C2. The second division not quite so far, and the third division not quite so far still. Arranged first, second, third in the tract as these fibers descend through the middle posterior hindbrains into the spinal cord. In the caudal third of this tract, they give off secondary collaterals to a laminated nucleus, associated plate nucleus, looking exactly like that in the spinal cord. Nucleus of Lissauer's tract, nucleus of the spinal tract of the trigeminal. Marginal platinous approprious elements, and crossing fibers to join with the spinothalamic tract fibers from the spinal cord, going up to the thalamus, more conscious sensation, but giving rise to reflex segmental, intersegmental connections or responses to pain. There are also medium-sized fibers in this ganglion.
Did they make the same three connections?
Sorry?
They make the same three connections in the association flow thing, responding thing?
Right. We'll come to that as soon as I get the sensory plate in place. We'll come back to the association plate. The medium-sized fibers come in and do exactly the same thing in terms of primary collaterals, but give off secondary collaterals to a nucleus which is just lateral to the motor nucleus, the main sensory nucleus. So I really should have planned ahead a little bit better and put the pain temperature system a little bit not quite so far in. So I'll make these smaller and have them come into the tract, which is going to continue just laterally to the nucleus as it comes down. So the main sensory nucleus, in a lateral view, essentially overlaps the motor nucleus. So when you look at a cross-section of the pons, you expect to see both of them, or neither of them. The main sensory nucleus is comparable to the nuclei of the posterior columns for medium-sized fibers of the spinal segments. It gives rise to crossing fibers going up to the thalamus for conscious sensation. And then we come to the mesencephalic nucleus, the large fiber system, which, as we've said before, has large cells up here in the mesencephalic nucleus. A primary collateral that comes out to jaw muscle spindles, and a secondary collateral to the anterior horn cells of the jaw muscles. So schematically, the nucleus lies up in this angle, not at this level. It just comes down into the upper part, but not very far, with secondary collaterals here, and primary collateral coming out here to the spindle. So we have exactly comparable intra-segmental monosynaptic reflexes for jaw jerk, tapping on the chin, stretching muscle spindles, reflex contraction, maintain the status quo, back to the positions we were in before. The only major exception is the central location of these large cell bodies, primary neurons, whereas all other muscle spindle systems, all other sensory systems have their ganglia out peripherally and arise from neural crestomes. So we have then a reduced motor plate, only one laterally placed nucleus, motor 5. We have 3 sensory plate elements, small, medium, and large. The large one being exceptional in its position, the others being unexceptional by now, having peripheral location in the Caesarean semilunar ganglion, peripheral distributions through the 3 divisions of the trigeminal, and primary rootlet fibers that come in and branch rostral-caudally and give off secondary collaterals to the nucleus, the main sensory for medium-sized fibers within the same segment, and this caudally displaced spinal tract of the trigeminal, the caudal third of which we think we know about, in the sense that it has exactly the same organization as spinal pain temperature systems. So any questions on this so far? Let me then put in the nucleus of the spinal tract of the trigeminal and its three divisions: rostral, caudal, and intermediate. There's this caudal part that we know has three components that receive the secondary collaterals from the trigeminal, have intrasegmental connections, so we have a very polysynaptic basis for the reflex connections we'll talk about next. Any problems? I have to put in now another major nucleus, motor, of the middle hindbrain segment, facial nucleus. This curious course out at the junction of pons and flella, going out to facial muscles. Because this becomes critical for a very important reflex, the corneal reflex. When one touches the cornea, first division trigeminal bare nerve nets are activated. Ganglion cells, bodies here. Descending primary collaterals, secondary collaterals into the nucleus of the trigeminal tract, and connections made either directly or through reticular formation to the facial nucleus and out to face muscles, including periocular muscles for blinking. So it's a rather slow polysynaptic reflex response to pain in the cornea. If you look at the reflexes that you can obtain around tapping the eye and record them electrically with time, this axis, and your stimulus tapping around the eye at this point, what you will find in recording from muscles around the eye is a sharp response and later a prolonged response. This is the monosynaptic stretch reflex evoked from spindles in facial muscles that come in through the trigeminal with their cell bodies up here in the basal trigeminal nucleus, and a connection that has not really been demonstrated anatomically that I know about, but coming down to make monosynaptic connections with the facial nucleus and a response, monosynaptically, a rapid response out to the facial muscles. This, now, is the eye blink. Everyone sees the pain. A polysynaptic response involving descending tract of the trigeminal and its nucleus and the facial nucleus also. If you cut the spinal tract, the trigeminal, which one's obliterated? Second. It's not completely obliterated, but it's markedly depressed. So there may be other collaterals, secondary collaterals, more rostral. Because you recall that Sjöqvist in his 1930s attempt to relieve pain in the face deliberately chose the trigeminal tract in an attempt to preserve the eyelid. And it turns out that enough is preserved for protective purposes, but if you really measure it, it is depressed. The monosynaptic reflex, of course, persists. You cut the descending tract all you want, and that doesn't affect it. You cut the trigeminal root, the first division of the trigeminal, and of course both of them disappear. Just as you cut the facial, both disappear. So any problems on anterior hindbrain? Well, let's march on up in the midbrain. Let's start on that one. Midbrain is an entirely different looking section. I should add the roof of the aqueduct, fourth ventricle, and the claviculi up here, cerebellum behind. So when I make a section through the midbrain, you'll end up looking something like this, with an aqueduct, periaqueductal gray, a claviculus, peduncle, a claviculus, peduncle, interpeduncular space, substantia nigra, and a lot of tegmentum reticular formation. Some minor different terminologies used here. We have a tectum, or roof of the aqueduct, or the claviculi, or the quadrigeminal plate. If you look at it from behind, you see four bodies, right and left, superior and inferior claviculi. So all of those are essentially synonymous. Below the aqueduct we have tegmentum. Just as we had tegmentum in the more caudal segments, anterior and middle hindbrain, and even down in posterior hindbrain, reticular formation of the brainstem. And then we have a cerebral peduncle. And here terminologies diverge a bit. In one terminology, the line peduncle includes substantia nigra as well as the bases, pedunculi, the base of the peduncle. Most commonly today, we separate the substantia nigra and the cerebral peduncle as gray and white matter. But historically, you will find this term, for the two of them, So one has a way of dividing the midbrain into three parts. In ancient days, not consciously doing it three ways, but a roof and a tegmen and a pedal. For reasons that are peculiar and unexplainable, I prefer the other terminology where we divide into four parts. This segment contains motor, sensory, and association plates, but they're moderately reduced in size and location. We have a nucleus, the third, motor, whose anterior horn cells give rise to fibers that come down and penetrate the medial portions of substantia nigra and bases, cerebral peduncle, and go out as a third cranial nerve to most of the extraocular muscles. And now I'm going to perform an operations in order to save some space in the diagram. I'm going to make a cut. And we'll say this is the superior colliculus on this side, the third nerve nucleus below it. This is now going to be the inferior colliculus. So I've taken a centimeter wedge out of the tectum in order to show the fourth nerve nucleus at a, we'll call it level. This anterior horn cell arises curious dorsal course crossing the midline just below the inferior colliculus, coming out into the subarachnoid space, around the midbrain, and going out as the fourth cranial nerve, out to one of the extraocular muscles, the superior oblique, which is most easily remembered as a sulfate radical SO4. We know that the sixth nerve nucleus down in the middle hindbrain comes out to go to the lateral rectus, and so all the other extraocular muscles are supplied by third. We have no lateral motor plate. But we do have a dorsolateral. This, the Edgar-Westphal, which is an autonomic preganglionic. These fibers go out with the third nerve to intraocular muscles. Preganglionics, postganglionics. Through the ciliary ganglia. So, of the motor plate elements, only two by position, only two by function. We don't know the gamma system. And a very strange course for the fourth cranial nerve, in particular, and its fibers come back around. But most of the third cranial nerve nucleus behaves itself quite well and goes straight forward. Most of it being ipsilateral, like most anterior horn cells should be. Now, the way I remember which of the extraocular muscles is supplied by opposite contralateral motor neurons is to remember, first of all, the fourth, completely crossed, and go into the superior oblique, and then remembering the functions of the extraocular muscles. Digress a bit for that. The eyeball, looked at from above, has an anterior-posterior axis and an equator. The lateral rectus muscle attaches laterally, and medially. So they're very simple. Lateral, medial, rotators. Lateral rectus, of course, is sixth nerve, medial rectus, third nerve. The superior oblique muscle has a tendon which attaches behind the equator to the lateral side of the AP axis and comes up forward, hooks around a hook there, but the muscle itself lies back in here. So this is superior oblique. Here we have the fourth nerve, and the angle that it makes with the AP plane here, this angle, is .52 degrees, is that right? What I said 9 years ago, Mike? I didn't want to give you the wrong answer. 51 degrees. And the other angle that's important is now the superior rectus, which attaches in front of the equator, and the angle it makes with the AP axis here is 23 degrees. I'll write it first, put it second. Right. So those are the two angles you have to remember to get the whole eye oriented. And it turns out that the superior rectus is supplied by the third nerve contralaterally, just as the superior oblique is supplied by the fourth nerve nucleus contralaterally. So the two angles that you have to remember relate to the two muscles that are supplied by contralateral neurons. In the motor plate. So we have a few of the third nerve fibers that are coming from the other side, crossing here to join. I have to cut out my wedge there, I can't show it. So bodies coming out to go specifically to the superior rectus.
Decided the orientation of the globe was here. I mean,
oddly enough, I was about to go there. Now that we've got the fundamental anatomy here for the various muscles, you can remember that the inferior blank muscle is exactly parallel to the superior blank, but on the bottom surface, and its muscle is in a reasonable position. It doesn't have a tendon like the superior blank, but is exactly opposite to it. And the inferior rectus is exactly parallel to the superior rectus on the bottom side. So what we say about one of these pairs will apply oppositely to the other. Begin with the simple ones, lateral and medial rectus. All they can do is go lateral or medial. So look at my right eye. The lateral rectus can only go that way. The right eye can only go that way with medial rectus. They're pure AB or AD adductors. The superior oblique, which is one of the most interesting ones, it has this curious neural input, has actions that are dependent upon which way it's oriented. If you turn the right eye, from above now, to the nose, 51 degrees, it becomes a pure depressor, an elevator of the back of the eye in the line of action of the tendon. And so if my right eye is looking way over here, to the left, 51 degrees, the fourth nerve will pull the back up, push the front down, and it's a pure depressor. Conversely, if I turn the eye laterally with the lateral rectus, the complement of this, 39 degrees I guess would be, so if the eye is now this way, the action will be to take the lateral side of the eye, the equator now parallel to the action, and elevate it. If I'm rotating the eye, my right eye, like so, go the outside and press the medial side. So in one position laterally it's a pure rotator, intorter, and the other position medially a pure depressor. The superior rectus, again, is a pure elevator pulling the front of the eye up when the eye is directed 23 degrees laterally. More laterally, more medially, it introduces a twist to it, a rotatory component. But now I have to tell you my favorite story about the superior oblique and the fourth nerve, which happened when I was at Walter Reed as a lowly captain of neurology, and then Major Hayes, who eventually became a general, was chief of neurosurgery, and the possibility of operating on the midbrain for relief of pain by cutting the ascending pain fibers as they were coming up here laterally in the midbrain presented itself. I had a young soldier with pain, and so George was in there, and I was looking over his shoulder, and he was looking down here, coming into this region from behind, and there was the fourth nerve in the subarachnoid space. He was sucking away, and whoop, she said, there goes the fourth nerve. And we all joked a little bit that. But the next day, George called and said, Buster, that wasn't the fourth nerve after all. It must have been just a little piece of arachnoid. The patient does not have the focus. And so I said, oh, it looked awful thick for that. It looked like nerve to us at the time. He said, yes, but there's no nodopopia. So I went over, and there was the patient, lying slightly sitting up in bed. George said, "See?" We asked the patient to follow repeatedly around and up and down, and no diplopia. And I said, "Now wait a minute now." He said, "Now follow my finger closely down here." And he said, "I see two fingers." Now, Noel, what was the difference? Why did he lie to George and tell the truth to me?
It wasn't lying to everyone.
Hmm?
It wasn't lying to everyone. Just that his eyeball was oriented in such a way that it was very oblique.
I didn't hear the whole answer there. My batteries were going low or something.
His globe was oriented in such a way that the superior oblique couldn't move because his innervation was gone.
Right. So the right was the right fourth nerve, and so the right superior oblique was out. But why did George miss it?
Because he was just having the eye rotate and playing directly from.
No, he just said, "Follow my eye down here." And said, "Didn't see double."
Was his head tilted?
He was, as you can imagine, post-op, he wasn't moving very much. And Mike knows the answer from 9 years ago. That's good, old memory. The problem was that George examined with his finger like this, and what the patient saw was two fingers like that, an extension. He didn't recognize the other two. If you turn it like this, nice, he's two like that. That's easy. So it was the fourth nerve, and it did have diplopia in the right place. But you have to make the problem easy for him to see double if you want to make sure that this is so. So that introduces me to the concept of how you test for diplopia. And one of the easiest ways, of course, is a colored glass. In those days, we had red glasses, but not always available. We had plastic dictaphone discs. So it turned out to be a green plastic test instead of a red glass test. It does the same thing. It makes one object normal color and one abnormal color. And that makes it easier for the patient to say, "Oh, I see two, a red finger, a green finger, and a normal finger, where it's a spot of light." And that becomes far and away the most sensitive way of making the patient see double, making it more difficult for him to fuse or to misinterpret what he's seeing. But basically, you have to know the actions of the muscles and how to get them in their optimal position for you to interpret the diplopia that the patient will see if the muscle is weak, neuralized. So any problems on Noel? Any problems with extraocular muscles? Well, let's come to intraocular muscles. And for this, we need a little more space than I allowed myself, but let's have a pupil, behind which is the lens, and the iris around the pupil. The iris has radial fibers and circumferential fibers. So one system is designed to constrict the pupil, the other to dilate the pupil. And it turns out, of course, the constrictors are innervated by the close ganglionics of the third nerve. So when one shines a light into the pupil, the visual system, which is not really a part of this segment, so I have to steal it from the brain. We have a retina with its 3 layers of cells, and output eventually through optic nerve, chiasm tract, back to the pretectal area. And a nucleus that makes connections to Edgar-Westphal nucleus bilaterally, and the Edgar-Westphal nucleus I've got to put in up here, making its preganglionic connections, postganglionic connections out to the intraocular muscles, in this case specifically the muscles of the iris.
So that reflex is not monosynaptic?
The light reflex is by no means monosynaptic. It has 3 neurons in the retina, a 4th neuron here in pretectal, a 5th at Edgar-Westphal, and a 6th out in the ganglia, or not ganglia. So there's outward constricting muscles of the iris, constricting the pupil. So just as you stop down the iris of a camera, because you have too much light coming in, that's the response to light. And it is bilateral at the level of the, what color did I use? Green. Pretectal nucleus is schematically out here. Rostral comes in and supplies the Edgar-Westphal nucleus bilaterally around the aqueduct. Having received the 3rd retinal fibers, ganglion cells coming back to the nerve, chiasm tract, and another crossing, of course, occurs in the chiasm. So we have bilateral or broad source of light, input, and bilateral connections to the output. And so we have the 2 irises, constricting response to light in either eye. Even if you restrict the light to 1/2 one field. So that's half of the intraocular muscle problem. Any problems?
The output from Edgar-Westphal is not crossed.
That's correct. The output from Edgar-Westphal is ipsilon. Any other problems? The lens behind this pupil, if we look at it in cross-section, is suspended by ligaments with muscle going around it, so that when that muscle contracts, the lens becomes thinner. And when it relaxes, the lens becomes muscle. When it relaxes, the lens becomes thicker. when it contracts, it's going to allow the ligaments to relax and the lens becomes thicker. I said it backwards first. And when it becomes more round, you're focusing at a near object. So in the relaxed state, you're looking at the distance. In the contracted state, you're looking at a near object. And that's part of the attempt when shifting from distant to near object to focus sharply. You have to accommodate the lens and you have to constrict the pupil to, just as you would in a camera, you would stop down as far as you can in order to have the least spherical aberration of the periphery of your lens. And both of these functions are accomplished through Edgar-Westphal nucleus and the output of the ciliary ganglion, this one to the ciliary body, this other one to the iris muscles. In the normal individual, when you ask them to shift from distant to near object, the pupil constricts, and that's what you see. What the patient sees, and what you define the thickness of the lens is thicker, and the patient is accommodated to that near vision. Now you can lose these reflexes singly or in combination. One of the commonest situations is where you have transtentorial herniation. The medial temporal lobe comes down and compresses the third nerve, and it shifts the brainstem away, presses on the third nerve, and it happens that pressure on the third nerve is almost the only way that mechanically you can paralyze the preganglionic fibers, and so the pupil dilates. I left out the sympathetic, which goes to the dilator muscles, so that's still active, and you paralyze the parasympathetic, third nerve, and the pupil dilates on the side of the compression. And that you see every day in terms of brain tumors, abscesses, hemorrhages, whatnot. And it's generally a bad sign. It requires some treatment. That's the problem. The other extreme is to blind the eye. Disease of retina or of the nerve, chiasm, and the blind eye, of course, does not see the light, but the pupil will still react to stimulating the other eye with light, or by having the patient attempt near vision. One of the neatest examples of that I know of is a patient with acute methyl alcohol poisoning with alcohol, which selectively enters the vitreous, converted to formaldehyde, fixes the retina nicely, killing off the ganglion cells, and making the eyes blind. And there you see this gal having been poisoned with bad alcohol, bad liquor. Pupils dilated, can't respond to light, can't see a thing, the world is black, and yet her pupils will constrict if you ask her to do what, Eric? Look at her nose or look at her thumb, where she can still remember where they are. She converges, and the pupils constrict. She can't see a thing. The purpose of the convergence, of course, was to see singly. The purpose of the accommodation was to see sharply. Those are still preserved even though she can't see. And so it remains to be explained how those reflexes are initiated. One would have expected that the visual cortex, the conscious vision, would be involved in saying it's out of focus or it's in focus. Sort of like the automatic camera that you have oscillating back and forth and just trying to zero in on what should be sharp, automatically focusing. But the blind patient obviously is not taking advantage of that bit of the nervous system. And that's, for example, he leaves the muscle spindles in the lateral rectus muscle, which are being stretched in the action of convergence. And would imply these two right and left lateral rectus muscles and their spindles have important segmental or probably intersegmental connections, probably involving the mesocephalic nucleus, which should be the site of the cell bodies for those spindles, and the connection somehow to heading to Westphal nucleus for accommodation and pupillary constriction. However, the neatest patient I've seen that contradicts that is the patient with extraocular muscular dystrophy, who has no movement in his eyes at all. The muscles of fibrous tissue. And he's just standing there looking straight ahead, seeing double, and anything that comes anywhere near him. Can't converge, yet his pupils constrict on attempted near vision. So I conclude there has to be at least two different parallel inputs for accommodation to near vision, for the lens and the iris to respond. One probably involving visual cortex and conscious vision, conscious focusing, even though you don't converge. I had a classmate in medical school too, who had blinded eye long before as a child, and had lost convergence. So when he converged with one eye, the other one was lateral, but his pupils constricted. So convergence is not necessary in that kind of a patient, or the extraocular dystrophy patient, nor is conscious vision necessary, as in the methyl alcohol poison, where it's purely peripheral retinal damage. So I conclude that both of them are working in parallel to allow this pair of reflections to work. Any questions?
Could you explain the Argyle Robertson people and the 80s time people?
Okay, Argyle Robertson is easy. We don't know. Every attempt that I've heard has a failure built into it. The difficulty is that the Argyle-Robertson pupil is a somewhat complicated little window. The pupils are unequal, and they don't react to light. They do react to near vision. They're also irregular. One of the neatest explanations was a ventriculitis with encephalitis around the periaqueductal inflammation that destroyed these connecting fibers from pretectal Edinburgh-Westphal. And if that were the case, one could have light coming in and accommodation going out, but no light replaced. That would have been the neatest explanation. The only trouble is we just don't see it in the case of this study. The next explanation said, well, maybe there's a subdivision of the Edinburgh-Westphal nucleus, one for light and one for accommodation. So there'd be a partial loss of neurons in Edinburgh-Westphal nucleus, selectively those for light. And again, that is fatal anatomically. Seeable. Third explanation is that out here in the ciliary ganglion, there's a subdivision for light and accommodation. There's some anatomical evidence for that in terms of injuries, peripheral injuries, stab wounds, in which one or the other has been destroyed. But it seemed to be a very exceptional situation, and a lot of argument about whether there really are two ganglia out here that have separate functions. Still other peripheral explanations have been, well, in the diabetic who has a classical Argyle-Robertson pupil, he also has synoptic atrophy. There's a selective loss of light reflex fibers more than of light conscious vision fibers. That doesn't have much appeal. And then you come down to the fact that the pupils are unequal and irregular. And that to me implies that there's an iritis. There's a peripheral damage to the muscles of the iris. Unequal on the two sides. So, as I said, it's easy because we don't know the answer. My suspicion would be that there are multiple possibilities, and that with syphilis, a common cause of the Argyle-Robertson pupil, there are multiple sites involved. Hades tonic pupil, on the other hand, is almost the opposite, in the sense that the pupil is unilateral, and the affected eye constricts and stays constricted for a long period of time in response to light, or dilates in response to dark and stays dilated for a long period of time. It tends to be seen in young women who tend to have asymmetric knee or ankle jerks. And so temptation is to immediately label them examples of tertiary neurosyphilis, which doesn't strike a receptive chord either the young woman or the mothers or congenital syphilis. And it turns out that it's not, that none of the other characteristics, including the fact that the patient will tell you, sometimes the pupil, that the inequality changes. Sometimes the affected pupil is smaller than the other, or sometimes larger. And of course, the patient doesn't really know which is the effective one, usually, but they recognize they're unequal. Inequality might be different. The test is fairly straightforward. Just shine a light, get the pupil constricted, and see that it stays constricted. Or put her in a dark closet for a few minutes, so it dilates, come out into light, and stays dilated. As you can demonstrate in a matter of a few minutes, there is a tonic pupil maintaining for some minutes the previous position in which the light or absence of light is put. And the implication is, I think, that it's a peripheral lesion, although